Hey, I'm jumping in right here at the very beginning of the show. I realized I recorded this episode last week, and as I went to post it, I didn't mention in it that I am doing a promotion this week on the Dream Job package. And if you're not on the email list, I don't want you to miss out on that opportunity. The Dream Job package is a method and a way that I get you to the top of the resume stack and then show you how to rock the interview, even if you have no experience. We tackle all of that. So if you're graduating 2022, this is really a great package for you to get your hands on. Again, it's only running Thursday to Sunday. I'm also offering group coaching along with anybody who's getting it this weekend. So that'll really up the value because you can get your questions answered directly from me in that setting. So I think it's going to be a lot of fun, and I didn't want you to miss out if you're not on the email list. So again, the Dream Job Package promotion is running from Thursday to Sunday. You can find out more at www.physicianassistantexamreview.com/dreamjob, DREAMJOB, all one word. You can find all the information there. All right, let's get into the show for this week. Hello and welcome to Season 2, Episode 90 of the Physician Assistant Exam Review Podcast. In this episode, we're going to be moving through GI, talking about metabolic disorders. I'm Brian Wallace, the host and creator here at Physician Assistant Exam Review, where we help struggling and overwhelmed PA students dominate PA school and ultimately pass the PANCE and land their dream job. That's the point, right? To get a job and start helping people. If you get something out of today's show, please do me and someone else a favor. Share it with them. Tell someone else about the show. Tell someone else how much value you got from it. When you see your scores start going up and people start asking, how are you doing that? Please tell them how you're doing it. Please tell them where you're getting help from. Share it with a friend. This year in particular, I'm going to start building in to my routine, and you'll hear more about that as the year goes on, random acts of kindness. I'm going to start incorporating that into my program this year. This, you sharing the show could cover you for a random act of kindness, right? You could help someone else, you could help me, and then you get to feel good about it. It's a complete win. So go ahead and share the show if you find value in it. If you keep coming back every week and you keep listening, then clearly you are having some value in it. Please let somebody else know about it. All right. This week's show is going to be a little different than previous shows. I went into some detail about this in the last episode, and if you haven't listened to that, please go back and take a listen to it. That was on January 3rd. That one was released in 2022. I'm really excited about where 2022 is heading for me, for you, for Physician Assistant Exam Review. I've got big ideas, and I plan on doing a lot with the program and really growing things this year in particular. I've had some other time freed up and some great ideas hit me, and I'm really ready to go this year. One of those things is I'm going to start doing, rather than every other week, there's going to be a show every week. I'm going to remove the study tip, the test taking tip, the landing a job tip. That section is going to come out of the regular show, and that's going to go on in every other week to fill in. And I'm going to cover a lot more things throughout the year with 2 podcasts, one on medical content and one on improving your trip through PA school and beyond. And you're going to see how that unfolds moving forward. Last week being the first edition of that. The other thing that's going to be a lot different is I'm incorporating a learning idea that I use when I study with my kids, that I use when I study myself, and I haven't been giving to you on this show. And I realize it's kind of silly because one of the reasons you come here, you can get medical content anywhere, but one of the reasons you come here is because I have a specific way of doing things, of making things stick so that your brain holds onto them for test day. I have a system that I use, a way of thinking about it. And I believe that that's why you keep coming back here. And I want to take that further in 2022. And you're going to see as we move through today's session how that's going to work. So it's going to be a little bit different. It's going to be a little more repetitive. I'm going to ask more from you than I have in the past. In the past, I've asked for just the priming questions. I've asked you to contribute, to stop and think when we hit the priming questions and to use your brain. Well, now I'm going to need even more of that from you. This is not a passive show. This is not something you listen to in your car or as you run and you turn your brain off. This is designed to have your brain turned on as we cover this. And you'll see what I mean as we move through. So let's go ahead and get started, though, with our priming questions. All right, there's a couple extra today. I was pretty excited. So, number 1, fava beans are associated with what diagnosis? What diagnosis would you associate fava beans with? G6pd Deficiency. Speaking of G6pd deficiency, what might you see on a peripheral blood smear that would clue you into a G6pd deficiency? What would you find on a peripheral blood smear that might clue you into a G6pd deficiency? Heinz bodies and bite cells. Paget's disease of the bone typically affects adults over what age? Just change that in my notes. Over what age? I found older than 40 and older than 50. So it's important just to note, oh man, I'm doing this again. I'm handing you the answers to the priming questions. I'm just, all right, don't worry. I've got 3 more. I make this too easy for myself. Okay. Anyway, we'll come back to that later and that'll help you to retain it. Man, I wish I wouldn't do that. Anyway, a mousy odor should make you think of what diagnosis? This is one you've heard before. A mousy odor should make you think of what diagnosis? A mousy odor. Describe the picture of rickets. Describe the picture of rickets. And then lastly, at what age is the screening for Phenylketonuria performed? At what age is the screening for Phenylketonuria performed? Well, I'm glad I had extra priming questions in here because I obviously am going to need them since I ruined the first couple. Anyway, all right. So let's go ahead and get started. And I think you're really going to love how we put this format together. One of the reasons I'm altering the format, let me just get this out of the way up front, is that I believe strongly, and you'll have to go back to last week's podcast to get the full version of it, but I believe strongly that a good picture, mental picture of a disease will last you much longer than the flat, two-dimensional black and white image you normally get in your brain. You normally read through a section, or I read through a section with you, and it sounds like every other section. It's one of the reasons why I try to tell stories along with the diseases, why I try to come up with things that give them little hooks, because I think having that picture is so important. Then I think having the idea of what a clinical presentation looks like, what a patient looks like when they walk through the door is the second most important. Then the labs and studies. And finally, at the very bottom is the treatment. Most people get really hung up on the treatments. And to me, that's the least important area. And I talk a lot about that in the last episode, but real quick here, the reason for that is in the clinic, you can't make a treatment plan without a diagnosis, right? You have to start with a diagnosis. And realistically, you can get pretty far by looking up a diagnosis once you have looking up a treatment plan once you have a diagnosis, but it doesn't work the other way around. And to me, the same thing works on your tests. A lot of questions will ask for a treatment, but first they'll give you a vignette with specific signs of a disease, but not tell you the name of the disease. So you've got to make the diagnosis and then have the treatment. So we're going to be focusing a lot more on the front end and a lot less on treatments. And you're going to see as we move through, we're also going to add in a lot of repetition into today's show and into the shows moving forward. And again, that's something I use constantly with my kids and I torture them with it, but I'll tell you what, it really, really works. And I think you're going to like it a lot. So let's go ahead and get started. G6pd deficiency is our first one. G6pd deficiency is an X-linked recessive disorder. So it's more commonly found in males, right? X-linked recessive, more commonly found in males. That makes sense. It's also more commonly found in African Americans, in Asians, and patients of Mediterranean or Middle Eastern descent. Okay, so what is G6pd deficiency? It's an increase in red blood cell susceptibility to breakdown. That's what happens. You get an increase in susceptibility to breakdown through oxidation and some other means. And we're not going to go into the specifics of it because it gets kind of complicated and quite honestly, it's beyond what we're going to do here. But there are specific triggers that lead to cellular breakdown for red blood cells. So these people have the red blood cells don't last quite as long as someone without this issue. Normally, though, they won't have a lot of problems. Most people don't have any symptoms until a specific trigger leads to an increase in cellular breakdown. And then they have some obvious problems. They run into some issues with anemia. And what would happen, you can even think just a little bit through, if a chunk of your red blood cells started breaking down. All right, so some of the triggers for that. A bacterial or viral infection can cause that to trigger. Fava beans, ingesting fava beans can cause that to trigger. It's kind of funny when you think about it that way, but it's a reality. These are more common than you would think, and they're found in different types of flour. So people with this issue definitely need to be reading labels. Certain drugs can trigger this. Things like aspirin, antimalarials, sulfonamides, and methylene blue can trigger it. And then something like diabetic ketoacidosis can also trigger it. So one more time, G6pd deficiency is an X-linked recessive disorder, so it's found more commonly in males. It causes an increase in red blood cell susceptibility to breakdown, which is caused by a trigger, not just automatically happens all the time. It's when there's usually a specific trigger, like an infection, ingestion of some material like fava beans or drugs, or a patient goes into something like diabetic ketoacidosis. Now, what is the clinical presentation for a person with G6pd deficiency? Well, they may have some jaundice and they may have some dark urine. Those tend to be the things. They may also have some fatigue. We're talking a little bit about anemia here. Fatigue. All right. So if this is a issue with red blood cells, what kind of labs and studies are we going to be looking to get? How are you going to diagnose this person? If you think they have some jaundice, some dark urine, and some fatigue as they come through the door, you're going to want to get some tests, right? Well, you're probably not going to want to start with x-rays. You're probably going to start with some blood tests. And here in particular, we're going to start with the CBC. So you're going to be looking for anemia. And the other thing that's going to cue you in here is an elevated retic count. Why do we get an elevated retic count? Do you remember from hematology? An elevated retic count is when your red blood cells are being destroyed or there just aren't enough of them, either because you're hemorrhaging or because the red blood cells are being destroyed for some reason. Your bone marrow starts to put out these baby red blood cells, which are the reticulocytes, right? Those are the red blood cells that aren't quite ready yet. So you get an increase in circulating retics. Now, in that peripheral blood smear, this is the priming question I gave away a minute ago. In the peripheral blood smear, you may see bite cells and you may see Heinz bodies, which will push you a little bit more towards that G6pd deficiency diagnosis. And you can also there is a G6pd assay, so you can actually test for this once you get pushed a little further and a little further in that direction. Now, we're going to hold off on treatments for just a minute. We're going to move on to Paget's disease, and we'll be back. But I want you to start building that image in your head. G6pd deficiency starts to create a situation where red blood cells break down with certain triggers. All right, so Paget's disease. Paget's disease of the bone. We're not talking about breast cancer here. We're talking about bone. So this is a chronic condition that involves accelerated bone turnover with disorganized remodeling. So what we mean here is that your bone's always turning over, right? You're always making new bone. You're always creating new bone. You're always breaking down bone. But in this case, it's happening faster than it should be. And when it gets put back together, it's not exactly put back together correctly. There's a gradual onset here, so it's not something you notice right away. And it affects adults, so typically people over 40, which is what I accidentally said in the priming question. 40 to 50 and a little bit older is where you see this. So this isn't a disease for kids. And as we create those colored in pictures, this is what I want you to see. Paget's disease will not have a question about a child. It won't be a pediatric question. This is an adult issue. It can occur in any bone, but it's most commonly found in the pelvis, the femur, and the skull. Clinical presentation. All right, so we've got a bone issue where we've got an accelerated bone turnover with disorganized remodeling. What do you think these people are going to come in complaining about? So draw this picture in your head. Again, this is an active podcast. This isn't just you sitting in the car and listening to me. This isn't you on our jog, just listening and zoning out. What do you think someone with an active bone disorder will come into the office complaining about? Well, the number one issue for these people is bone pain. That's what brings them into the office, is pain, stiffness, fatigue, arthritis. And They can get some pathological fractures, which means that the bone becomes weak from a disease, and then get enlarged bones in strange places because of that remodeling going on. So if you have a bone issue and you think someone comes in complaining about bone pain, what do you think you're going to get as far as a test or a study for these people to try to complete your diagnosis, try and complete your picture? Well, you're going to get an x-ray, right? That's a great place to start with an x-ray. And Paget has a distinct appearance on x-rays. So you're going to get a bunch of x-rays to look at the problem, and hopefully you're going to be able to tell that it is indeed Paget's. Another test you're going to get is a blood test. The alkaline phosphatase will be elevated, and calcium is usually normal, and that's sort of a red flag for Paget's disease. You can do a bone scan to look for uptick in activity in the bones, or if you can't get a good clear diagnosis, a bone biopsy will work, but obviously you want to try to avoid that. Most people don't like having pieces of their bones taken out to get looked at, but certainly it's an option. We're going to hold off again on treatments there and come back around. Our next one is Phenylketonuria. So let's make sure we understand what we've got so far. So we've got G6pd Deficiency, which is that X-linked recessive issue where we make red blood cells become susceptible to breakdown from specific triggers like fava beans or drugs. We have Paget's disease of the bone, which is a chronic condition that involves accelerated bone turnover and disorganized remodeling. So you're going to see this in older patients. And now we're going to move on to phenylketonuria, which you're going to see in much younger patients. We're going to contrast these two to make them stand out a little bit better. This is an autosomal recessive trait. So you need two recessive alleles to make this happen, right? In this case, the patient produces a low level of the enzyme that breaks down phenylalanine, which can lead to toxic levels of this amino acid. So what you get is much higher levels of phenylalanine than is okay for the body to have. So what happens here is the patient never, ever has enough of this enzyme. So this is a problem from the time the patient's an infant. This happens right away. Initially, they'll have no actual symptoms because the mom has been able to break down phenylalanine. It'll take a couple of days of ingesting proteins to notice this problem or for serum levels to increase. So there's a newborn screening that's done in all patients, especially in the United States, where they do a stick of the heel of newborns at days 2 to 7, and they measure the phenylalanine in the serum, and that's how we test to make sure to see whether they have it or not. Because as you'll see, that makes a big difference in treatments and how things move forward for these patients. All right, so clinical presentation and physical exam findings. I just told you, what did I just tell you about the picture for phenylketonuria? How does it look so far? So what we have is a newborn baby who can't break down phenylalanine. Okay, so our clinical presentation is going to be limited in that setting. That's why we do the screening. But as it progresses, if we don't catch it, and we get that toxic buildup of phenylalanine, the patient can get hypopigmentation, meaning very fair hair and skin. They can have seizures. They have very serious hyperactivity. And then they go on to progressive mental impairment, and they miss developmental milestones. They wind up with learning disabilities over time. And these are not curable. You can't go back and fix these later if they're not caught very, very early on. The other key term that comes out here a lot is the mousy odor in the urine and the sweat. That's just one to mark down and put in your book as a key term that should just trigger you. As soon as you hear mousy odor, you should think phenylketonuria. But so over time, you develop these mental problems. And again, these are non-curable. They are what they are once they occur. And then our labs and studies are going to be that heel stick for newborns right out of the gate to make sure that we treat these people appropriately. Lastly, today we're going to be covering rickets. Rickets is a disease resulting in the softening and weakening of the bones. Now, there's a couple different variations on this, but we're not going to go into detail on pretty much any of them. I don't think it's worth the time for your PANCE or your PANRE. I certainly wouldn't go further down this road than to think that it's typically caused by a vitamin D deficiency. That's the problem we're going to go with. Like I said, there are a handful of other reasons you can wind up with this issue, but that's where we're going to be, is a vitamin D deficiency leading to softening or weakening of the bones. Your risk factors or causes here is a diet lacking in vitamin D, calcium, or phosphorus. Low sun exposure, because that's one way we create vitamin D, dark skin, and celiac disease. Your clinical presentation here is going to be, again, bone tenderness or pain, pathologic fractures, bowed legs, so you get the tibias bowing out. And what you're going to do is get again, x-rays here, a skeletal survey, because we're looking for a skeletal problem. So it's a complete set of x-rays. Labs and studies, serum calcium is usually going to be low, serum phosphorus usually low, and vitamin D, of course, is going to be low. All right, so let's run back through these one more time, just to make sure we've got sort of a more clear picture in our heads. A G6pd deficiency is what? Give me sort of the rundown on G6pd deficiency. So we have a patient who really has no symptoms, no problems, until what happens? Until there's some kind of a trigger. Well, what can we use as a trigger? What are the things that cause G6pd to come out? Bacterial or viral infections, drugs like aspirin or sulfonamides or methylene blue, diabetic ketoacidosis, and then fava beans, right? That's our picture. What's our picture for Paget's disease? Paget's disease is a bone issue in adults, usually over 40, where they get odd remodeling of the bones. What's phenylketonuria? Think through the rundown for phenylketonuria. How old are our patients here? What are we talking about? What we're talking about is these patients don't make enough of an enzyme that breaks down phenylalanine, and it rises to toxic levels that can cause mental disorders. If they never make enough of this, it's an inborn trait. It's an inborn issue. This is an autosomal recessive trait. We want to get on this right away. So we're talking about infants and very, very young kids where we would see the symptoms. And lastly, we have rickets. And again, so give me mentally, think through, take about 10 seconds and think through the picture for rickets. Maybe less than 10 seconds. I can stare at the clock for 10 seconds. Rickets is typically caused by a vitamin D deficiency, and it is a disease resulting in softening and weakening of the bones. All right, so we've got our pictures for today. Let's talk about how we're going to treat each one of these. G6pd deficiency was that breakdown in red blood cells, right, caused by a trigger. They're going to come in with jaundice, dark urine, fatigue. What are our treatments going to be for these patients who typically have no symptoms except when they get exposed to a trigger? Well, the very obvious treatment is going to be avoid the triggers. No fava beans, right? No aspirin for these patients. We're going to try and keep them at a DKA. Those are the things we're going to do. It's really just prevention for a G6pd deficiency. And then supportive care, right? So fluids and whatever we can do to help with pain and blood transfusions if necessary. It's pretty rare, but it's possible. Let's think through Paget's disease. What was Paget's disease? Well, that was our bone turnover with disorganized remodeling in adults. What are we going to do for these people? Again, it's mostly going to be supportive care. We're going to use NSAIDs for pain, and we're going to try to support them. You can use bisphosphonates, but they have their own drawbacks, so that's sort of a balancing act. Phenylketonuria. How are we going to handle this? So this is a situation where we don't make enough enzyme to break down the amino acid phenylalanine. So how are we going to handle treatment here? What's the mainstay of treatment going to be? Well, it's a diet low in phenylalanine. That's not incredibly easy because it's a very common amino acid. So it's hard. It's in a lot of foods that we eat. I didn't go through and list them all here. I don't think it's something you need to memorize, but it's like turkey, eggs, fish. The list is incredibly what I would call very normal foods in an American diet, things you'd see a lot of. So you would have to do a diet low in phenylalanine. Now you need some phenylalanine for brain development, so you can't exclude it completely, but you want to make sure those levels stay low. And then there are supplements and different protein mixtures now available that provide nutrition with low phenylalanine. All those things are available, but the overall idea is a diet low in phenylalanine. All right, let's think through rickets. Rickets was what? Well, a disease resulting in softening and weakening of the bones, typically caused by vitamin D deficiency. Well, how do you think we're going to treat a vitamin D deficiency? How about we increase in the diet vitamin D and calcium, we supplement with vitamin D and calcium, and we provide sun exposure, which is going to give us an increase in our vitamin D. Perfect. All right. So that'll wrap up our discussion of metabolic disorders that falls under GI and nutrition. Some of that seems odd to me that it would be here, but it is, so we're covering it. No big deal. Normally, this is where we would go into our study topic, but we're not going to do that today. I'm going to keep this clean and just straight to medical content. So we are immediately going to move into our priming questions and answer the ones I answered already for you and continue the conversation and answer the ones I haven't answered. Fava beans are associated with what diagnosis? We've been over this 50 times now. Come on. Fava beans are associated with what diagnosis? G6pd deficiency. What clues for a G6pd deficiency might you see in a peripheral blood smear? We talked about this in the beginning. I didn't review it a lot, but we did talk about it. Heinz bodies and bite cells. Paget's disease is typically found in people over what age? This is important because you're going to see it in your question stem and your vignettes. Over age 40. A mousy odor should make you think of what diagnosis? A mousy odor should make you think of what diagnosis? Phenylketonuria. At what age do we screen for phenylketonuria? 2 to 7 days, right? 2 to 7 days old. We want to catch this really, really early. And then do me a favor and let's describe the picture of rickets. What is a patient? What does rickets kind of look like? What's the makeup of it? Low vitamin D, leading to poor bone production and soft bones. Without vitamin D, the calcium can't get laid down. We don't make good bones. Really pretty straightforward stuff. All right, great. So we finished up with our discussion of metabolic disorders. We're moving through GI. I think we might have one more, possibly two more discussions left on this topic, but really that's about it. So I'm super excited to have this new format. I think it really is going to help you retain more information, take up just a touch more time, but really be super valuable in helping you to hold on to that information longer. And I hope you got a lot out of today's show. Again, if you did, please share the show. Please tell a friend about it. Please show other people how you're retaining so much information and how much further ahead you're getting in school. Let them know exactly how you're doing it by telling them about the show. And I will see you again next week now as we're doing shows every single week. All right, take care.